Is my myeloma responding to treatment? Am I in remission? And how do I know?
The difference between response and remission is that response in general means that patients have an improvement in their monoclonal proteins, their light chains, something to suggest that myeloma cells are dying in response to therapy. Remission can have a variety of different pre-specified, detailed definitions that are tough for a physician to describe to a patient. When I say you're in remission, does that mean a complete remission? Does it mean a stringent complete remission? Does it mean a stringent complete remission that's PET negative and MRD negative? There are a variety of very picky levels. So I always say to patients who ask me very often, so am I in remission? I always describe the details. There's no myeloma protein in your blood, there's no myeloma protein in your urine, and your bone marrow biopsy on standard specimens, or if I did MRD testing, was all negative. And that's usually the definition of remission. And I provide details so that the patient comes away with it, understanding if they didn't meet remission criteria, what was it that still led me to hold that back?
A common question we get is how do we evaluate and measure response for multiple myeloma? So let me start with some general comments. First of all, the word response and remission are synonymous. This is very important because people sometimes think, am I in a remission? And from a medical perspective, when we think about remission, we're thinking as the same as thinking of a response. And what we do is that we further qualify what level of remission you have. So in the medical journals, you will find a partial remission or a partial response as synonymous. Now, how we qualify it is just by how deep the response goes to. And it's interesting because you see that the goals of responsiveness have tracked along with our ability to control the disease. We take it back 30 years, people were said that plateau was sufficient, meaning the proteins came down, they're not going down any further, but they don't seem to be going up. Now, we know that's woefully insufficient. Modern criteria have focused essentially on three types of responses. We have a partial response, which is a reduction of 50% of your protein markers. Then we have a very good partial response, which is almost complete elimination of the disease. You're talking about just residual markers, usually a small amount of a protein or something that you can measure, and that's how we measure, we determine a very good partial response, which used to be an old interesting criteria. And then one step up from that is what we call a complete response. And a complete response means there's complete disappearance of any of the usual markers that we test to determine if there's residual myeloma or not. Now, we got better with treatments, but we also got better with measurements. So then there's what's called a stringent complete response, and that is one level higher. And what that means is that if you were to look at the bone marrow and you do the testing for those plasma cells, or you look at other markers like the light chains, everything remains normal. Now, up to this point, you could have a stringent complete response. You had a great success with your treatment, but we have known that it is possible that there still are some cells hiding in the background. So we wanted to take that one step further. And that step further is what's called the MRD, which stands for minimal residual disease testing. And that result can come back as positive or negative, and that can also come back with a number that quantifies how many cells are left behind. There are generally two ways of doing this. One is called flow cytometry, which requires a fresh sample and live cells. And there's also that's done through genetic sequencing, or NGS for next generation sequencing. This types of tests can take the sensitivity down to one cell out of 100,000 in the case of flow cytometry, quite routinely, when it's established by sophisticated laboratories, to 1 in a million when you use the genetic sequencing. And what that test will tell you is, of the million cells that were tested, did you find any evidence that there's any residual myeloma cells? So it's very, very deep testing. For the audience, and there's other videos here talking more in detail about MRD, but keep in mind that if the test is negative, what we say is that there is no evidence of disease. But we are not saying that there is evidence of no disease. In other words, even an MRD testing that is negative cannot be used to say 100% that the person is cured from their multiple myeloma. But nevertheless, it is the best result possible when we think about the treatments that we give to patients.
Does remission or response mean that I'm cured?
I think we need to be very clear what we're talking about when we discuss responses with patients, because there are certain terminologies that have a totally different meaning for patients in essentially layman terms. So many patients may equate remission to cure, and we do recognize that myeloma at this point is not a curable disease. We can put patients into long-term remissions or responses, but the disease can come back at a later point. The same is true for other malignancies as well. So I actually have this conversation with my patients and clarify when we're talking about remission or response, we're not talking about cure. We're not talking about the disease is gone. It's been suppressed to a very low level. We can't detect it, but it still can come back.
How long does it take to know if a treatment is working?
Oh, that's a really good question. It kind of depends. I mean, some things you can really tell within, weeks to a month. Other therapies, you have to be a little bit more patient to see. But with tests like, the free light chain, you can usually tell if you're going in the right direction after a cycle or two.
If I have a partial response to treatment and my disease is stable, do I change therapies or wait for a better response to the current one?
You'll get different answers from different people. So number one, some therapies, it does take longer. So you might see some response after cycle 1, but by cycle 2, you'll see even more, and cycle 3, even more. So again, you can see that sort of drop. Sometimes people will hit plateau, so the protein won't change much. And then the question is, do you change therapy or not? It depends, So if for induction, if you're going to take somebody to transplant and they got like a partial response or something, and it's not a VGPR or a CR or whatever, I'll just take them to transplant. I won't be changing. I think sometimes you can lose patients. They won't necessarily make it to transplant if you kind of keep changing. If a patient, is elderly especially, and they've gotten some response and they're doing well, by all means, I'm happy. They have stabilization. If they don't have significant anemia, their bones are stable, I think that's wonderful. Or if somebody's multiply relapsed and they have, sort of get stable disease, it's called clinical benefit, deriving clinical benefit. Sometimes you will carry on with that. I think the answer is it depends.